Case number 3, thank you.
Okay.
Excellent. Okay.
Well, do you see us though?
I see case number 3. I see Jason Kovacic. Hello, Jason. And I hear George Dangas.
I'm right here on the left, but I'm a little taller. You don't see me much. There you go.
Okay,
In
good.
between Jason and I, we're throwing off the height.
And Dr. Kini
the
right
height
there.
resolutions there. That's why I have Dr. Kini with us.
Okay, so we have case number 3, who is a TAVR AI. So if you just see, we are in a TAVR room, which you will see interventionalist. You have our surgeon, who is Alan Stewart, and we have a vascular surgeon, Dr. Tadros.
Rami Tadros right here, coming next to me, Dr. Tadros. Yeah, he is.
All
He is
right.
expert cutback.
Okay, quickly we are presenting the case, GD.
75-year-old patient with dialysis.
We can't hear you.
75-year-old patient with dialysis post-bypass.
Okay.
Pacemaker, severe COPD, and various other comorbidities, including diabetes and CHF, is an inoperable case of severe AS, as well as with some moderate degree of mitral annular calcification. The baseline EKG is a 30-degree heart block, and other than that, the bypass is closed. The LAD has moderate degree, about 50-60%. We do believe the bypass was in the time with an unsuccessful angioplasty with a dissection, so it was patent for some time. Patient did very well, but subsequently bypass closed because obviously the dissection must have healed. So this is the overall scenario. The patient deemed inoperable due to all this comorbidity, STS score north of 10.
So a patient with class 3 symptoms, severe AS, post-bypass, CKD on hemodialysis, already on a permanent pacemaker, obviously high risk, not an intermediate risk, high risk. So a lot of calcification. What's your strategy? How are you performing this? Go forward.
Well, next slide, please. And we can review the echo. You can see the high velocities.
Okay,
Over 4.
Dr. Chowdhury, can you just, he's our echocardiographer.
No.
They
Go back one slide, please, to the echo, and Dr. Chowdhury can give us a summary of today's TE.
Okay, Dr. Chowdhury. We can't hear you, Dr. Chowdhury. The mics need to be all fixed in that lab. We can't hear him at all.
No mic.
George, is the patient on conscious sedation?
No, the patient...
No, one second. Let's proceed then. We're going to get Dr. Chowdhury in a little bit, but let's say that
patient had to have a GA.
Significant aortic stenosis here. Show the next slide. You can see the CTA that indicates impossibility for this is the valve CTA that you can see the annulus. Jason, you want to give this review?
Sure, good morning everyone. So the main feature of this annulus is that large blob of calcium about 430 that you can see there. So the perimeter is about 67.9, area is about 3.6, but the diameter across the valve is about 19 in the short axis, 23 in the longer axis, but across that blob of calcium is only around 16, 17 millimeters. So quite a challenging anatomy. The risk in this case, we have to balance here, is the risk of annular rupture if we're too aggressive with post-dilation versus how much paravalvular leak we're going to accept in this case that may be leaking around that calcific nodule. Next slide. Just to take you through the CT now. Next slide. Good, so here you can see the LVOT. Dimensions are about, diameter is about 19 millimeters. The calcific nodule does extend down into the LVOT, which is another feature that we have to be mindful of for risk of annular rupture. Next slide. Next. Here you can see the SOV, mean diameter is 29, which is adequate for the size valve that we'll be coming to. Sinotubular junction height is 22, ascending aorta 27, all very reasonable, but of note you can see the calcium extends up into the leaflets in that upper panel there. So quite a lot of calcium associated with this valve. Next slide. Here you can see our access plan, and this is quite complicated. The patient already has a pacemaker. The patient has a dialysis fistula in the left arm. So really left subclavian access was problematic in this patient because to do a left subclavian access, and we'll come to the iliacs in a moment, left subclavian would require us to take the pacemaker out of its pocket to get to the subclavian vessel underneath the pacemaker pocket, and if we had complications, we'd also mess up the dialysis fistula. Right subclavian was unsuitable due to severe disease. Next slide. So here's the transfemoral access approach. You can see a lot of calcific disease, and at the common femoral access point, again, a lot of calcific disease. Next. You can see here some of the dimensions. Just to summarize this, bilaterally the minimum diameter is 3 to 4 millimeters, not quite circumferential calcium, but severe calcific disease the whole way up. We normally need around 6 to 7 millimeters for easy access. This is well below that, but because of the problems with the subclavian access, this was actually our preferred route of approach in conjunction with our vascular surgeon, Dr. Rami Tadros, who does a lot of these kind of access cases for doing TAVR and EVAR with very large sheaths. So he has a deep experience in getting in and out of these kind of vessels safely with large sheaths. Next slide. So just to summarize the valve choice, it's a 26 millimeter Evolut. We're going to go with the Evolut-PRO, and Dr. Kini and Dr. Dangas will talk about that. But by all sizing measurements, this is perfect for a 26 Evolut valve. Next. So
the summary of the case is a critical AS with a high syntax, with a high STS score, inoperable for comorbidity reasons as well. And we had a right femoral cut-down access with Dr. Tadros. We're going to proceed with a BAV with a 18 millimeter according to the lower diameter of the valve. And while we went up with a BAV, you can see we have the confida wide in the ventricle. We have a 20 French sheath. I'll let Dr. Tadros speak a little bit about the access while we went in with a BAV.
Before that, we have to tell them the important question. I think one question from Ron Waxman is, what's the anesthesia? Right now, patient is under GA because of the cut down that we had. Otherwise, we have at least 60% of ours are under conscious sedation, the TAVR that we do. When they are cut down or the subclavian that we do, then they're going to have a GA. And once they have GA, of course, we will have a TE. Otherwise, majority of the cases, I would say 30% of the cases, echo will be done transthoracic. Otherwise, they will have a pediatric probe and do a echo at the time.
So I think one of the most important areas here, and I want to just, as you guys are pulling in and out, is the fact of this nodular calcification on the valve that I think we're all concerned about, worrying about a rupture, but balancing that without having a paravalvular leak.
You can check TE after valvuloplasty.
Josep is here, Rhodes, Kabul. Josep, how would you approach, would you choose Evolut-R here, or would you go with Sapien? How would you choose this? Tell us what you think about this.
I would, my choice would have been also an Evolut-R without predilation. I think that the amount of oversizing would be enough to seal the annulus,
so you would
and
not do
having
balloon.
a good result, direct TAVR, yeah. In these cases, we try to avoid any balloon dilation.
I
Okay,
agree,
that's
because I think
interesting.
that you can get again the same rupture from the balloon.
Okay.
What were you afraid to do with the
What was the TE
expendable?
after the balloon? Can you do a TE, please?
That was a very interesting
Yeah,
point
even
that they
if
have
the balloon was
raised.
not a big one,
So did you guys hear that? So
Yeah.
the panelists are questioning your pre-dilatation and valvuloplasty.
Excuse me, Roxana, I want to intervene. Recommend pre-dilatation because I think that the danger of annular tearing or rupture is most when if you have to post-dilate the self-expanding valve. So the danger of annular rupture during post-dilatation or self-expanding valve is higher than during pre-dilatation.
Right, so you feel that this, so it's interesting. It's a nice, interesting comments here. Talk to us how you're positioning your valve,
so
who's
now
speaking, who's
what you
placing.
have is same. You will have the pigtail in the non-coronary cusp. You see that? That's what George is adjusting. And this is where we have, T can come up a little bit, please. T come up. If you see that, this is the implantation view. So if you see the implantation view, you will see on the right side of the screen where you have to see your 3 sinuses, and that is when you see the lower part of the 3 sinuses, you will draw a line that is called as the
Let's play this view, Jason. Play this view, Jason. Off floor a little bit. Play this view.
Their question was, why do we
Right
do
here, we have
VAV?
this pre-implantation view
Yeah,
that
yeah.
you can see here.
You see
And,
that?
Yeah.
You
well
can see
aligned
nicely the
sites.
three cusps.
And the
but you're
bottom
not
of
in the
the three cusps,
non-coronary
where
yet.
you draw the line, is the annular plane, and that is where we are focusing to have our valve just about 4
Dr.
millimeters
Chaudhary,
just below the annular.
post-valvuloplastic or severe AI or no?
No, no.
No.
So you move,
Very good.
you move the pigtail now to the non-coronary because
Yes.
before
Okay.
it was
Right now
not.
Ready?
we moved it to
Inject.
non-coronary.
Yeah. That's fine,
T up, please. We don't need T at this time.
I think
Looks
we're good.
good. And
Let's
we have
start, let's start the
The
deployment
T is
a
just a
little bit slowly.
disruptor.
So the steps of deployment here very simple. He's going to start rotating
Pace
after
100, please.
Slow
start.
and
Yeah,
go very slow.
Okay, we have stop Cine. Inject. Nice. Now the next rotation you start flaring. When you start flaring, I'm going to give the instruction of pacing at 150.
Let test, please.
Pace 150. This is the time you want to
So
decrease
you
the cardiac
flare
output.
and you start
Good.
pacing, and now
And that's the
you're-
time you start releasing.
Jumped in
Stop.
deep. It's
Okay,
very
stop.
deep. It's very
Inject.
deep.
I think we're okay.
It's pretty
Yes
deep.
and no. Let's see a little bit.
Patient already has a pacemaker.
Yeah, just do it slow so it's not
Now,
going to sink in
very
further
important
in.
at this time you have to make sure there is no parallax, which means your the diamond of the posterior part and the anterior parts are lined up. Why is it very important? That it gives you the accurate information, the view of the depth of the implant. So if you check your parallax, we're looking good.
Yeah, I think that
Another view,
there's minimal parallax
yeah,
here.
minimum. Very nice. I think we are good. We are ready for release.
Well, let's
unless
check
the
it. Let's
parallax
check it with Dr. Chaudhary also. Let's check the T a little
Yeah,
bit.
let's hear
We
about
have a
the
little
echo.
question there.
What are you
Chaudhary,
looking?
check a little bit on the T point of view, the depth.
What are you looking on the echo right now at this point? Because the valve is not completely deployed, so you're going to have PVL at this.
No, we're only looking at the long view now to see if we're too deep.
Angiographically looks good.
I don't think so over there.
Okay, we are ready to deploy. Pigtail is out.
Just do it
Echo up.
slowly,
Echo up.
very
Echo up.
slow.
Can you show us the fluoro, please?
up.
Full screen fluoro.
Echo up.
Right, thank you.
Now you have to be very careful. We just want to make sure all the is completely released. Okay, wire.
So you
let's-
already pulled the pigtail out
Come back.
before you
The
deploy.
pigtail is up, and we're doing a little maneuver by pushing the equipment all the way in before we take it out to align with the push the wire in, please. Push the wire in.
And take the wire out.
Very good. Okay, T can check now again.
So the key point for the TE, of course, is that the calcium is extending from the
Jason, you
mitral
have
That's right.
annulus and leaflet, and
Wanna
that's
take it
where
out?
the
We might as well take
LV
it out.
outflow tract
Just flare a little bit.
component is.
You guys are we're a little bit getting out of time, so you're going to need to show
No,
us.
we are actually done here.
Well,
If
we're
it looks
sort of
good-
done here. What do
Yeah,
you mean out of time? Let's see what the T results shows.
Well, you were supposed to do 4 cases, and we only got done through 3.
I
so
understand,
you got to do
but-
better.
We are done.
Because I would like to proceed to our
Go next case.
Well,
Ready?
You've
top
talked,
topics.
they did it in 10 minutes.
Not yet.
Not yet, but
Not
let's,
yet.
I know,
You're
but
ready for the fourth case? Yeah, lot of paravalvular here.
okay. Show us your results, please. of your valve.
Guys, unless we deploy the valve, we don't have a complete case. So, we cannot rush and complete the case before the valve is released. Just was done. So please, TE can show the post leak, and we're going to put a pigtail in the LV.
And the hemodynamics,
Chaudhary.
George.
Dilate here, big leak.
Post.
Post dilate first.
You need to post dilate here. It
Post
looks.
here.
Yeah, I'm not sure.
I
Probably.
can't see.
Probably you need to.
He's
yeah.
saying minimal.
Can we hear Dr. Chowdhury and the echo, please?
You can see that the frame is not very well expanded at the
Exactly.
area
You
of
leave
the
it.
LVOT.
Diastolic pressure.
Yeah,
is
but
good,
sometimes
echo,
with
nothing.
some minutes the
Okay,
valve
let's go
continue to
with the 20
expand,
Zimet balloon dilation. I mean, 20.
So, Dr. Usia, they still have to post dilate here, even with the pre-dilatation.
I will wait
so-
a few minutes, and also
Yeah,
I
sometimes you
will
can wait.
check the hemodynamics.
I'm not so sure. Let's Dr. Chaudhary again. Let's show us a paravalvular.
I see it. We can't hear Dr. Chowdhury at all.
He's saying there's a
Minimal
paravalvular
paravalvular.
leak.
Minimal paravalvular.
So if you see the hemodynamics, why are you showing the echo in 2 screens? Can you show hemodynamics or no?
Okay, let's put the pigtail in.
Maybe we ask the panel.
See what they think.
What is the diastolic pressure? What is the end diastolic pressure? These are also
Diastolic pressure
parameters.
is
Well, we don't have a diastolic pressure because
diastolic
I
we
haven't
don't
crossed
have.
again.
He's going to cross right now.
You do
back
have it
in.
now. No, you do have diastolic pressure now.
Yeah,
Joseph,
let's-
So that's
would
a
you
good
post
diastolic
dilate?
pressure. It cannot be a lot of
Want
PVL.
us to cross?
I'm not sure here. I
sure
would I
yet.
would pull
Let's
back
cross
the
with
wire,
detail.
Yeah,
and I will do hemodynamic measurements and then an angio.
exactly.
What,
Another echo evaluation,
what's
but
the
I think the
recommendation
result
from
is good.
Dr. Usia? I did not hear that earlier.
Dr. Ucia?
I would put a pigtail, measure the hemodynamics, and then I don't think it is needed valvuloplasty. I think is good. Maybe if you can.
You see the jet? There is a jet there.
Yeah, but
Well, there is a jet, but a small.
can we have also another projection? Maybe a right anterior oblique with the caudal.
Okay, let's see the hemodynamics.
For me, it's the hemodynamics at this point going to make the final decision. Because there is always a risk again on those patients.
Yes, of course.
You should forget about this. I have this other pressure.
Yes,
here.
and with the S3, you have your immediate
this other
result.
pressure.
But with a self-expanding valve, it continues to
Give me
expand.
Yeah.
It's not working.
It's not working because I haven't opened it.
Can you show us the hemodynamics on the full screen?
Okay, there.
Yeah, we see the hemodynamics.
Here we go.
It's perfect. It's good.
Oh,
Yes,
yeah,
it's
yeah.
good.
diastolic pressure is 16.
I think you are done. You have good
That looks
hemodynamics.
really good, huh?
And yeah, you
I
probably
think we're
should be
good.
okay. Yeah.
That looks good. Is that enough for everybody? Just the hemodynamics, even though you're seeing
It's not
little
enough,
jets?
but it's in addition to
enough,
what
right?
you're seeing on
Yeah,
the...
I want to hear from everybody.
Echo, angio, hemodynamics.
Echo plus hemodynamics. Carlo?
If you have no issues with creatinine, why don't you inject without, of course, the
Ready?
wire and just confirm that is
Ready?
a minor leak?
Ready?
I mean, we didn't see full screen the TOE,
Okay, T
so
up.
T up.
All right.
5-10% of the
minimal,
circumference.
minimal AI by the final
By every measure.
every measure, and given the fact that we have the Pro,
That's
the Kovacic-PRO here with an external wrap that allows advanced sealing of the last 1.5 cell at the bottom of the valve, about 14 millimeters. So this will allow, I think, over time, hopefully,
It will keep
small leak
expanding.
to get rid of it.
It'll keep expanding, and then hopefully in the 48-hour echo will look good.